Today I want to introduce my thesis proposal with the title Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. My presentation includes 6 parts. First of all, the rationale. Heart failure with mildly reduced and preserved ejection fraction accounted for over 50% of overall heart failure and associated with high mortality. Inspiratory muscle weakness is one of the components in heart failure. The prevalence of inspiratory muscle weakness in heart failure is very high, and this figure in heart failure with preserved ejection fraction is 30 to 40%. Inspiratory muscle weakness is defined as maximal inspiratory pressure, or MIP, less than 70% of predicted value. It's not only a symptom, but also a prognostic factor in heart failure. Inspiratory muscle weakness makes exercise intolerance, dyspnea, poor functional capacity and quality of life. And inspiratory muscle training, or IMT, is an approach to strengthen inspiratory muscle. By that way, improve and reduce above symptoms. Until now, 2 trials were performed to evaluate the efficacy of IMT in heart failure with preserved ejection fraction. But both studies used low to moderate intensity IMT. In addition, they used unblinded trial design, small sample size, and lack of report of the compliance to home-based IMT program. An interesting finding is no previous study evaluated effects of IMT in heart failure with mildly reduced ejection fraction. So, the gap of knowledge is that there have been no study performed to evaluate the effects of and safety of high-intensity IMT on patients with heart failure with mildly reduced and preserved ejection fraction. Based on the current evidence, we propose 3 questions. Firstly, does the home-based high-intensity IMT program increase VO2 peak from baseline more than in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction? And the second question is that, does the home-based high-intensity IMT program improve MIP, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters? And the third question is there any difference in the safety of home-based high-intensity IMT program compared to sham controls? The literature review. The treatment methods in heart failure include medical therapy, comprehensive care, and cardiac rehabilitation. And inspiratory muscle training is one of the components of the cardiac rehabilitation. The mechanism of inspiratory muscle weakness in heart failure comes from many factors, including respiratory muscle atrophy, change in muscle fiber types, muscle metabolic reflex, reduced oxidative capacity, ventilation inefficiency, and physical deconditioning. Additionally, there are some other factors affect inspiratory muscle weakness, such as aging, nutritional deficiencies, obesity, medications, and comorbidities. Just like any other muscle, the respiratory muscle also need to exercise, and IMT is a type of resistant training which is proposed to enhance inspiratory muscle strength. 3 components of IMT include intensity, frequency, and duration. The intensity depends on the percentage of maximum inspiratory pressure, or MIP, and divided to high intensity, moderate intensity, and low intensity. The mechanism of IMT in heart failure. Inspirator muscle training could improve inspirator muscle endurance, increase exertion capacity, alleviate metabolic reflex, enhance diaphragm thickness, and change muscle fiber types, and improve ventilation efficiency. By that way, IMT improved functional capacity. As I mentioned in previous section, there are two studies of IMT in heart failure with preserved ejection fraction, and both of them shows the significant improvement. There are some common outcomes that related to IMT in heart failure. Firstly, peak oxygen consumption or VO2 peak. It is peak oxygen uptake during the exercise test, and it reflects exercise capacity. 6-minute walking distance and diastolic function based on the results of echocardiography. Quality of life. We will use SF-36 questionnaire to assess patients' quality of life. It is conceptual framework. Heart failure with mildly reduced and preserved ejection fraction will present with inspirator muscle weakness. Inspirator muscle training or IMT will have to increase the strength, speed of shortening, power output, and endurance of the inspirator muscle. By that way, primary and secondary outcomes may be improved. Research methodology. We use randomized controlled trial design. Heart failure with mild reduced and preserved ejection fraction in heart failure and heart outpatient clinic of King Chulalongkorn Memorial Hospital will be assessed for eligibility. They will be excluded if they meet exclusion criteria. Then they will be randomized to two groups, allocated to high-intensity IMT or sham IMT. The eligible criteria. Inclusion criteria include patients with diagnosis of heart failure with preserved ejection fraction and mildly reduced ejection fraction with age more than 18 years old and NYHA class 2 and 3. The exclusion criteria include gait problems, worsening heart failure, recent angina or open heart surgery, end-stage renal disease, post-heart transplantation, anemia, moderate to severe valvular disease, significant primary pulmonary disease, and comorbidities with life expectancy less than 1 year. And it also includes withdrawal criteria, not interest with the study, hospitalization for other reasons, stop training for 6 days, new illness acquired during training period affects the results. We will use block randomization method with a block of 4 and 6 in a 1:1 ratio in two groups. Cardiologist, outcome measurement, and data analysis researcher are blinded to patient allocation group, and participants are blinded to one other intervention. The intervention protocol, high-intensity IMT, will be warmed up in 5 minutes. The training resistance will be set at 30% of MIP in the first week, 50% MIP in the second week, and 70% MIP from the third week. The cooldown will be performed in 5 minutes. Sham IMT will be warm up and cool down similar to high-intensity IMT. The training resistance will be kept at 15% of MIP. The study endpoints, primary endpoints, is the change in VO2 peak at 8 weeks. Secondary endpoints include maximal inspiratory pressure, 6-minute walking distance, quality of life, and diastolic function, and experience of some adverse events. The compliance will be managed by a logbook and the phone call every week and the checklist. The data collection timeline from the admission to the end of the intervention. Sample size calculation. We set the power of study at 80% and alpha level at 0.05. We calculate power for VO2 peak using data from previous similar study. The results show that 12 participants per group is necessary to achieve adequate power with effect size coherence of 1.256. The sample size for two groups is 24 patients, assuming that 15% of patients will drop out of the study. So the total participants is 29. Statistical analysis. Intention to treat analysis will be considered. The normality of data is examined by Shapiro-Wilk test. Independent t-test or Wilcoxon ransom test will be used. Depends on the distribution of data. Chi-square test or Fisher effect stat will be used for categorical data. Statistical significant level is p-value less than 0.05. The limitations. Some problems with compliance could arise, but we use phone calls and diary to alleviate the limitations. I intend to apply for 19th anniversary of Chulalongkorn University scholarship to serve my study. The ethical issues. Cardiac rehabilitation is not implemented as a mandatory routine in the King Chulalongkorn Memorial Hospital. So comparing a high-intensity IMT program with sham controls allow for a fair comparison to user care while ensuring a non-biased and blinded study design. We also provide consent form and opportunities for the patients to ask any question, and participants can withdraw from the research at any time. This is my study timeline, and I'm in the first stage. Thank you very much for your attention.